Welcome, everyone. I'm Malisa Carullo. I'm a naturopathic doctor and currently run the clinical team at Metagenics. Today, I have the pleasure of speaking with Dr. Charles Serhan and learning more about specialized pro-resolving mediators and inflammation. Dr. Serhan has quite an accomplished resume academically and has received numerous awards for his work. He is a top-cited researcher and a pioneer in the area of inflammation resolution, and as, of course, most of you know, he's known to Metagenics for his discovery of specialized pro-resolving mediators, which most of us know as SPMs. He joins us today from his office at Harvard University. I'm very excited and especially honored to have this opportunity to speak with Dr. Serhan. So welcome, Dr. Serhan.
Hi, how are you today?
I'm so well. Thanks so much for joining us. We have many listening in that are clinicians today, but also many that are consumers or patients. And so we're just wondering if you could, start off this conversation and share a bit about you and your background, how SPMs were discovered and why they're so important.
Okie doke.
Mm-hmm.
I'm currently the director of the Center of Experimental Therapeutics and Reperfusion Injury at Brigham and Women's Hospital, and I'm a professor at Harvard Medical School and have an endowed chair and was named a distinguished scientist back in 2000. But as you and your audience can hear, this is not a Boston accent. This is a New York, Brooklyn accent. So I went to school in New York and attended Stony Brook, was a biochemistry major there, and then went on to do experimental pathology and pharmacology at New York University School of Medicine. And I had a very unique opportunity to go to Stockholm to work at the Karolinska Institute as a fellow in the Samuelson lab when he received his Nobel Prize in Physiology or Medicine. So I'd have to say I got interested in inflammation as a student at NYU. There were really outstanding investigators there working on inflammation as it impacts rheumatoid arthritis and infection and hematology, and I was very fortunate to work with them. And then when I got to Sweden, it became really a thrust to understand the chemistry of the arachidonic acid cascade, which plays an important role in inflammation and in coagulation. And that was the basis of Professor Samuelson's Nobel Prize. And I mentioned this because he just recently passed 2 weeks ago and at 90, and it's a big loss for the field because he was the leader. And I have to say that I was very much inspired by him, and we just published our last paper together in 2021. So that's about it for the introduction.
Yeah, and we're sorry to hear about Dr. Samuelson as well. He was obviously an important mentor for sure in your life. Was it in his lab or working with him that you had come to discover resolvins, or how did you stumble across resolvins?
No. The resolvins were born in Boston many years later. But when I was in Samuelson's lab, we discovered some new structures that we called the lipoxins, and they were formed from arachidonic acid. And they were really a challenge to isolate and get the structures of because they were completely new structures at that time. And Samuelson always admired new structures and what they did biologically. And so when I got recruited to Boston, the quest was to figure out, what do these compounds do? And that's where we started to put the pieces of the puzzle together and realize that they were the body's own signals to regulate inflammation. And that became apparent by about the mid-90s. And there was one observation that really changed our way of thinking, which was that low-dose aspirin triggered the biosynthesis of a special form of the lipoxins. We call them aspirin-triggered lipoxins. They were epimers, and they were more potent and longer acting. Now, why was that such a big wow? Well, at that time, low-dose aspirin was thought to block prostaglandin production and thromboxane production. And thromboxane, you know, is important in regulating platelet aggregation and coagulation. And aspirin was thought to diminish or reduce inflammatory mediators. And here we had an aspirin-triggered pathway that turned on lipid mediators that signaled to stop cells from adhering to the vessel wall. And we thought that was very exciting, but it took another almost decade to isolate the resolvins. And how did that happen? Well, it was, like most things in science, completely serendipitous. We decided to set up a model in a mouse where we could interrogate with the techniques of the time the inflammatory exudate. And we decided to do that over time, to look at the initiation and then what happens later. And the results were surprising because we were looking for, by mass spectrometry, the prostaglandins and the leukotrienes because they help the inflammatory exudate to form, pus to form. And all of a sudden we started to see these new structures. I couldn't figure out where they were coming from. But we determined the structures of them and then realized that they were made in the resolution phase of self-limited, self-resolving acute inflammatory exudates, pus that would resolve on its own. And then when we added those back, gave them back to mice, it shortened the time to return to homeostasis. The resolution was accelerated. And we thought this was really exciting, so we synthesized all the molecules, studied their structure function, their biosynthesis, and continued to do that with human white cells, focusing on neutrophils because they are the body's first line of defense. And then a lot of exciting things started to come out in terms of stimulating resolution and defining in quantitative terms what resolution is, and then how these molecules work in regulating and preventing excessive inflammation and collateral tissue damage.
So your research must have essentially paved the way. It was this new wave of thinking because clinically, we're always taught, or we were taught in the past, to suppress the chronic inflammation unless it's acute scenario where, it's a healthy response, but, typically we suppress later on. So you really disrupted things, didn't you?
Well, I'm very fortunate in that we've had exceptional fellows and students over the years work with me to really expand the horizons around the resolvins. And we were focused on trying to make improvements in the pharmacopoeia. Because most of the drugs used today to treat inflammation, and I'm sure all your clinicians know this, and it might be news to some of the patients out there, that the downside of the non-steroidal anti-inflammatory drugs is that they eventually lead to immune suppression. And this is particularly relevant with the anti-TNFs. And those drugs were brought into existence by one of my former teachers at NYU, Jan Vilcek. And he had made an antibody against TNF alpha. And of course, it turned out to be really useful in controlling inflammation. But it turns out that TNF alpha, TNF stands for tumor necrosis factor. It was an unknown, but it was elucidated by the group at Rockefeller, up the street from us at NYU. And it became very clear very soon that TNF is also playing a critical role in host defense, in mounting our host defense against microbes. And therefore, if you take it down with an antibody, as in treatments used for arthritis today, it leaves those individuals susceptible to infection. So, as in all things in medicine, there's a good side and a bad side to treatment. So one has to be very careful. But I thought, and my group and my colleagues that work with me, that we can do better. We can do better. We should be able to do better. And the non-steroidal anti-inflammatory drugs turned out in our animal models to disrupt resolution mechanisms. Oh my gosh, they're controlling prostaglandins, but they're really throwing a monkey wrench into the body's own mechanisms to resolve. You say, well, what is that? Well, we mount an inflammatory response as a protection, right? A protection to host invasion by bacteria, viruses. When we get injured, we immediately mount a tissue level acute inflammatory response. This is what the pathologists define at the tissue level as the summoning of the white blood cells to come and defend us, but also initiate the repair mechanisms for the tissue. So we were very interested in that, and we really focused on, are there chemical signals that are specialized to the resolution phase? And that's where all the families came out. The resolvins were the first, and then the protectins, including neuroprotectin D1, and then the macrophage-derived mediators of resolution, we call those the merisins. And they are all produced by specific cell types that come and get recruited to the site. So when it came time to bundle this new class, the individual families, we said, oh, the lipoxins belong in there as well. So we group them all together because they control resolution. Now, the difference about the lipoxins is that they come from arachidonic acid. But the big surprise in the animal models was that the resolvins and the protectins and the merisins came from marine oils. Now, the serendipitous part of the research is that the veterinarians already knew and appreciated how important omega-3 essential fatty acids are to nutrition. And so the chow that the mice were eating was 30 to 40 times higher in EPA and DHA than arachidonic acid. So, of course, we were going to find them because they were much higher than if we had been searching around in in human pus, for example, where you would be in super health if you had 30 times the amount of EPA and omega essential fatty acids, because our body doesn't make them. We need to take them in our nutrition, and that's where we link up with the nutritionists, and I start to learn from them and their experience in nutrition, and then how to turn this into molecular medicine.
Yeah, you brought up so many different points. I can go down different avenues here, but I think I'll start with the EPA and DHA and how important that is, because I think that a lot of questions we receive at Metagenics is, so which ones do I take? Do I need EPA, DHA still? Do I just take SPM active? Do you have a comment on those at all?
Well, the best answer I can give is what I take myself. Okay,
yeah, tell us
so we can use this as the N of one. So currently, and my family, my wife as well, the SPMs are also include the intermediates in the biosynthesis of the very potent molecules, potent with respect to controlling leukocyte traffic. And so if you take an SPM with 17 HDHA and 18 EAP, it's about 100 times more potent than just taking their precursor, because they're converted more readily at sites of inflammation to the resolvins of the D series and E series. Now, the big surprise, though, is that those molecules, in and of themselves, when we first described them, we didn't realize how potent they are in controlling pain on their own, and also vascular. The 18E was discovered by a Japanese group and a former fellow of mine, Makoto Arita, who leads a very big group in Japan and at the Rankin Institute. And they discovered that 18-EAP was bioactive in remodeling the vasculature, and this was really exciting.
Yeah.
So now for the unbelievable part.
Okay.
So it turns out, as we study this in real detail, that if you take SPMs, which SPM active, for example, has 17 and 18, but it also has some, I've done some analysis on this, has some of the further bioactive products, the D series resolvins, and some of the E series as well.
Mm-hmm.
Now, if you take them and the precursor EPA and DHA are present, this turns out to be a feed-forward physiologic system. The resolvins stimulate the production of more resolvins from the precursors. So I follow taking SPM actives with taking DHA and EPA. So to really amplify not only taking the exogenous form, but enabling the body to produce more SPM actives. Does that sound?
That makes complete sense. I think you've put that discussion to rest with everyone out there I am telling you, we get that question so often at Metagenics. So I'm so glad you answered it that way. And obviously a lot of integrative docs, naturopaths, we've been giving, before SPMs were available, we would give tons of fish oil. Sometimes, in athletes, we would give 5 grams a day of EPA and DHA.
Yeah.
But how come, until SPMs were available, there was still like something in that pathophysiology that's been missing? Like, how come not everyone, essentially can convert EPA and DHA to SPMs?
Yeah, that's a really important question. First of all, there are sex differences. We have a new publication just coming out with a group from Germany. It was just accepted for publication. And females make higher amounts of SPMs.
Interesting.
And therefore do better on an inflammatory challenge. And in this case, our colleagues looked at colitis, inflammation in the GI tract. And it's an animal model. So if you could envision, and I hope no one gets upset with this, but this is basic research, gonadolectomy, then the males normalize and they can produce SPMs, and their inflammation in the colitis model is much, much reduced.
Interesting.
Okay, so we also found that there were sex differences we found surprisingly that tears the conjunctiva produces, and the lacrimal gland around the eye produces SPMs. And those values are higher in women up until the age of about 50, and then they drop off, which we think has something directly to do with dry eye in older women.
You don't even have to convince me. I completely agree. Like post 45 years old in my practice, the number of women who have that just tear constantly is unbelievable.
Sure. Yeah. And next week, we're going to present this data at the World Congress of Inflammation. One of the women in my group discovered salivary production of a special resolvent in humans. And her name is Dr. Malisa Carullo, and we're very excited about that work. We knew from some earlier studies that the salivary gland produces resolvents. And there's some very nice work from Olga Baker's group, and she's a periodontist, and she's looking at how saliva production of resolvents quiesces inflammation in and around the periodontium. Wow, isn't that cool?
All of them everything's so cool about this, yes. So we need EPA-DHA, we obviously need SPMs. If you take your EPA-DHA following your SPM ingestion, right? That's what you do. Then you might be better off, right? Did you track this at all? Are we sure?
Yes. And I guess the best answer I could give is that each individual out there, including the clinicians that are listening, really want to do this themselves and titrate themselves, and do it over a 2-week period. And yes, you could measure the increase in SPMs in peripheral blood, and there are labs that do that now, some really outstanding labs.
Commercially or just for research still?
It's pretty much for research, but they do it on a fee-for-service basis. For example, there's an outstanding leader in the field, Professor Marpati at Wayne State.
Okay.
And he has a lipidomics core that works for fee-for-service. And they use the methods that we prepared and published on, and we created all the standards that are now sold commercially. So he does that in those who may be listening in Europe. There's a group in France, in the name of the company is Ambiotis. And his name that runs the company is Dr. Mark de Bordeaux, and they do work again on fee-for-service, and they do measure, and they've published on measurements in humans. So how much do I need to take? Well, as I said, I think it's best for everyone to titrate themselves, and I would love to be able to introduce an easy dipstick, like a litmus paper, and being able to tell where we are. But it's really not at that level yet, the work. It requires a rather sophisticated liquid chromatography and tandem mass spectrometry. So there are only few experts that really have that skill, but they can do it. And if people really would like to know their values, they can go to those sources.
That's amazing. Yeah, I think a lot of clinicians might jump all over that, actually knowing that information now. Yeah,
I think if people are titrating themselves, they can very, very easily feel the difference in morning stiffness. They can very easily see the difference in their mood, how happy they are. And I know that sounds funny, but it's really true.
No, absolutely. Yep. And clinically, I think a lot of practitioners would agree with me that oftentimes, individuals, patients won't notice how good they actually do feel on SPM active until they start titrating down a little bit. And then they see the differences. Either it's pain coming back, their mood changes, a little bit of stiffness in the morning. So then they opt to titrate back up on their own and take more SPMs. So that's always good when they realize it themselves.
Try to recommend to your patients to try at least for 2 weeks, a third week for real assessment. And then I always like to encourage people to chart it down. If you're feeling great, give yourself a 5+ that day, 2+ in the evening. We also do take SPMs in the evening as well. And why? Okay. Because our studies have shown that the SPMs, and many other groups have seen this now too, it's getting really exciting, they stimulate, in addition to controlling inflammation, they stimulate stem cells. And I'm sure everyone listening knows that stem cells are the key to tissue regeneration. And this is occurring in places that we didn't realize that SPMs were having a function, like muscle stem cells. Beautiful work from a group in Canada, Dort et al. They've shown that resolvin D2, which is one of the ones that is in some of the SPM active capsules, stimulates muscle stem cells, and they're working towards trying to use resolvin D2 in treating muscular dystrophy.
Wow.
See, my personal goal, our mission of the lab, is to help as many people as possible. Our primary mission was to use these molecules as templates to build designer, more potent, less side effects, directed therapies, what we call resolution pharmacology, resolution medicine, to stimulate the body's own regeneration and repair and control of inflammation. But that takes a very long time. And just after more than 20 years now, there are several companies that have clinical trials that are starting with this year with the mimetics of the resolvins. And there have been 2 clinical trials so far with synthetic versions of like resolvin E1 in dry eye, 200 60 something patients with dry eye, positive results, and yet still there are barriers to get that moving further for more people. And it's not scientific, it's economic, it's the business guys.
Yeah.
And a company in Connecticut has picked up the call, and they are going into clinical trials in cancer with Resolvin E1, because we found that Resolvin E1 with our cancer collaborators, Dr. Deepak Panagrahi, that by clearing inflammation around the tumor, stimulating resolution reduces the tumor burden. Just unbelievable. So exciting. And I could not have guessed that or anticipated that. But we're intensely studying that right now, and we just received a grant from NIH and the National Cancer Institute. So I'm hoping we could make real progress there to help, again, as many people as possible. Yeah. So you might say, well, Charlie, can you use this as a preventative? Well, in my heart, I say yes. The data's not there yet, but I would follow the biology here, and it tells me, yes, we need to keep a peripheral blood titer of EPA and DHA around so that our body can make resolvins and similar molecules to keep things at homeostasis.
I would completely agree with you. I think I explain it to patients that way too, with anything, vitamins, minerals. There's new data with certain strains of probiotics that taking them can, mitigate the stress response. So it's really just this resilience, or putting money in the bank is what I tell my patients. We really have to get that savings account built up, really. Yeah.
The fact is that it's very challenging to have a meaningful clinical trial of prevention. And if you just do the thought experiment, you can see why it's so challenging, and why pharma companies don't invest in those types of.
Absolutely.
And the nutrition companies don't either, because it may not go their way, so they're not that interested. It's like an Agatha Christie novel. You got to follow the money. And sadly to say, in research and biomedical research as well, I always felt that, if something better came along, something so potent, everybody's just going to say, let's go for it, no matter what. But that's not always the case. So I say this because having the SPM actives as a nutritional supplement at least was able to get this information out and get it moving in the right direction and challenge people's thinking. And I said, well, how did that happen? Well, again, serendipity, we knew that EPA and DHA come from marine oils. Yeah. So I asked the fellows in my lab what they said, well, where do they get these oils from? It turns out that they get them from Peruvian anchovies. Hey, here's $20, go down to the store, buy some anchovies. So we extracted the anchovies, and we all were amazed that the anchovies, the fish and other fish that we've studied as well, produce the SPMs. Wow. And the paper just came out in January from a group in Norway, where they showed that the equivalent of the bone marrow in salmon, which is called the head kidney gland. It has
Mhm.
nothing to do with the kidney or filtration. It just looks like a bean shape, like a kidney shape. Makes microgram amounts of the D
Wow.
series resolvins. Wow. So this really makes us feel very, very confident that the structures that we elucidated are evolutionary conserved across many, many phyla, starting with fish. And and this gave us the opportunity to work with a company in Spain that had the ability at the time to isolate a fraction from the anchovy oil with the SPMs using a CO2 purification method, and that led to the creation of the capsules. So you might say, "Wow, yeah." So we got a patent on that, but we're not in it for that. But it's just to enable them to work, the company to work securely. So we gave them the patent for $1.
Amazing.
My wife is still annoyed with me about that one. But, you know, I I have the patent on my wall in my home office with the $1 check. Someday I'll show it in one of the talks.
And how much like change you've already, started just doing that it's been tremendous, right? Even just like the wave with Metagenics alone, like we're seeing so many different clinical applications of SPM active. It's absolutely phenomenal. I can't live without it. I just tell people I pop them like Skittles, like, like a candy bowl. This is what you have to do. It's really important. And I essentially have taught patients so well about them that they start telling their friends, like, you need SPM active. And like that's just how it snowballs, which is fabulous. Yeah, I think the work you've done, you should be, I know you're very proud of yourself, but we're all very proud of you. You're such a humble man to be here speaking like that. And we're just helping people live healthier, happier lives, right? Like that's all it's about.
Well, it really makes me happy to hear that, and it makes my group very happy too, because everybody invests a lot of time and energy into pushing the envelope. And we have new work coming up that I think you'll be really excited about, and is just in press now as of earlier this week, in the Journal of Molecular Medicine,
Mhm.
where with one of my colleagues, Nan Chang, I've worked with for a long time, we did an experiment to ask, can we train the resolution response
Hmm.
with repetitive dosing? And we did this in an animal model, and the answer is yes. And so you can clear faster a bacterial infection and an infectious inflammation. And I think that is going to be one where I hope people rush out to do a human study as soon as possible.
Would this be the reason why it wasn't originally touted for acute scenarios, but would that be one of the reasons why it works so well for acute scenarios then? The higher dose or constant dosing?
Actually, we're using a very low dose, but it's a very low dose every day
Constant.
or every other day.
Consistent. Yeah.
Yeah, so the initial thoughts about using the SPMs acutely came just from the time frame we were working in, that our add-back experiments were in short duration, the acute inflammatory responses, acute inflammation. And I felt that if you could reduce the acute response, that it would reduce and change the track going towards chronicity. So we can sort of change the program so it wouldn't become chronic. Well, but what happens, and I know you're thinking this, if you have chronic inflammation and you want to start to treat it, is it going to work? Well, we did that experiment with our colleagues who are periodontists and focused on inflammation in the periodontium. Why? Because this is a really good example of leukocyte-mediated collateral tissue damage. And we worked with Tom Van Dyke and his colleagues for many years, supported by NIH, NIDCR. I was the program director and principal investigator for a P50 Center grant, where we studied in first rabbit models of periodontal inflammation. Why? Because we wanted to treat topically and got really astonishing results, and then moved that up with the periodontist to mini pigs and found that the resolvins prevented inflammation-induced bone loss, which is like completely unheard of. And then we designed a mouth rinse to be applied topically, and 127 patients were treated with this mouth rinse, and Tom and his colleagues published the results. I wasn't involved in the clinical trial. I was only involved in the design of the mimetic and making the mouth rinse initially, and then everybody else took over to get it done without any conflict of interest. And so today, that mouth rinse is being sold in Finland, Norway, Denmark, and Estonia.
It makes complete sense. Yeah. Again, like I think we chatted about this a little bit last week, but you know, again, we're like the vagus nerve synapses and the autonomic nervous system. Like the first synapse is going to be right, like C1, C2, like right there, right? Like right where they're rinsing with their mouth, and then everything is going to be systemic from there throughout the whole nervous system.
That's right. You know, and also if people have chronic inflammation there to begin with, there's a barrier break, there's an opening that occurs, that the resolvins are really good at stimulating the closure of the mucosa in the airway, in the GI, in the vasculature. I think that's one of the main responses that the resolvins stimulate, is to control edema and barrier function.
Yeah. So, I mean, the thing is, like the preclinical studies you have done and other investigators, like honestly worldwide have done, are phenomenal. Like they are so good that it would almost be the prereq for clinical trials, right? So why are there not more, other than, you know, the money involvement, why are there not more clinical trials, like human clinical trials?
Yeah, that's the only pushback, is the enormous cost of the trial itself and scaling up. That was initially, when we first started, that was initially a big barrier to scale up the synthesis to make it really affordable. But real experts have come in since then, and they've been able to do that and beat that. The group in Connecticut, Thetis, they've scaled up and they have Resolvin E1 and make it really affordable. And there's a very, very good group in Hungary that scaled up and sells resolvins that are GMP for clinical trials.
Nice.
So it just still comes down to motivating the people to put money behind a trial. Yeah.
I don't want to take all your time, but I do have a couple more questions because I know this one comes up all the time by clinicians I speak to at Metagenics, and I'd love to hear your take on it. But, clinically, again, like it's similar to like vitamin D or a few other phytonutrients, where if you go to PubMed, there is like any disease state condition you type in, there's going to be some kind of preclinical where like resolvins have shown improvement for the patient. But I think there's a lot of clinicians who are still really confused, even though they've read the research, they've heard a lot of investigator scientists speak. They don't know where to incorporate this into practice. And unfortunately, my response to them is every patient should be taking this. Give it to anyone. Metabolic disease, acutely. I have patients with transient ischemic attacks, stress response. I feel like it can mitigate all of the inflammatory responses, but that response is not good enough for them. So how would you respond? How would they incorporate this into clinical practice?
Okay, so one of the surprises that we encountered about these molecules is that they not only are controlling the magnitude and the duration of inflammation, but they actually are directing the cells to do a better job at killing and clearance. So I think this is quintessential in aging and in any inflammation that would erupt as a result of injury or tissue damage. This is where you can use taking exogenous SPM active pills. Remember that from head to toe, the white cells roam and they patrol on the vascular endothelium. It's not that the resolvins are a panacea. They are not. It's that those mechanisms of leukocyte diapedesis and inflammation play an important role, from neural inflammation down to your big toe in gout. So it's that simple. It's not really. So of course you want to enable your body. I think that if we were to go back, and I learned this from Dr. Artemis Simonopoulos, and she's a pediatrician, who is probably the world's expert in omega-3s and nutrition. She introduced, or I should say popularized, the Mediterranean diet. And so Artemis, we wrote a small piece together, also with Richard Bazinet. We emphasized that when the nutritional balance of essential fatty acids was just right, without any manipulation, that your body was naturally making enough SPMs to prevent excessive inflammation. And as we come more to the current era, where our Western diet is devoid or severely diminished in omega-3 fatty acids, that the body is deprived of SPMs. So we're actually looking at an SPM deficiency state. If you describe it that way, you want to get back to a state of how the machine was supposed to work, if from head to toe.
Yeah, and I think just also important to remember that the immune system is always going to be involved and upregulated in all of these scenarios, these mechanisms. And then, as to your point, I think it also just goes beyond lifestyle, diet. It's just environmentally what we're exposed to every day, every second of every day, right? Certain careers that people, have, or they're exposed to chemicals all the time. So these are all things that I think we forget about exposure-wise that are depleting our or
Wow,
levels, right?
I'm really impressed. You hit
Oh,
the nail
thanks.
on the head
Yeah.
because
Mhm.
we have a grant now from the National Institute of Environmental Medicine at NIH, together with my colleague, Dr. Bruce Levy. Bruce is a pulmonologist, and he's the chair of medicine. And what we're looking at is how environmental exposures impact resolution mechanisms, and can
Mhm.
we correct that? Because it goes from everything from printed dust
Yeah.
that you're exposed to and to environmental exposures. You're right.
Yeah.
But those are all, again, getting back to what's triggering stress and inflammation.
Right.
And can we correct and get back to homeostasis with the SPMs? That's the question.
Yeah. And so for everyone listening, I think this is also one of the reasons why, there's different protocols out there for dosing, and some individuals, some practitioners will dose high at first for a week or a couple of weeks, 4 to 6 uh, capsules a day. Some will go as high as 10. I know I do 10 to 12 in some athletes with injuries. But this is the reason why, because there's really all these variables that need to be taken into account. So we definitely know now that we should be dosing them in a particular way, or at least we're going to try that. We're going to dose them, follow with EPA, DHA. I'm going to report back and see what I find in certain patients, Dr.
Right.
Serhan.
And we need to encourage Metagenics to come out with a topical form of the SPMs too, because I'm sure you've seen some of the research that my colleagues have done. Surgical incisions and wound healing is
Absolutely.
really accelerated. And so it'd be nice to have a topical.
I
And
agree. There's a couple competitors that have a liquid formula, but they're copycat formulas and unfortunately just don't work as well as the Metagenics formula. So that's exactly why we need to find a topical. And I would love to try that in patients for dry eyes.
sure.
I can't wait. I'm going to try those for sure.
Well,
Um,
the fun part is yet to come,
yeah.
because I was always very, I wouldn't say shy, but I was reluctant to do this type of discussion
Mm-hmm.
because I was afraid of being misinterpreted or misleading people. And, I'm just an egghead, and I know what's right for me. And I write papers and I teach fellows, and we're on our mission. But what's happened now is that the cosmetic companies have started to worry about inflammation and resolution.
Mm-hmm.
And they've come to me and I said, oh, is this a good thing or is this not so good? I said, no, it's a good thing, because if you make people feel better, they're going
For
to feel
sure.
better all head to toe. This is what it's all about.
Yeah.
So, sure.
Another reason why we're so thankful you are willing to do this with us today. We can't thank you enough. We need to talk to you more often for sure to get these little nuggets of information, because they're just invaluable. Like, we really, really appreciate your time.
Well,
So I'll
thank
just
you.
recap for everyone. Dr. Charles Serhan's with us, really the pioneer of specialized pro-resolving mediators. We're so grateful for him to be here today, teach us a little bit about these amazing, capsules that we promote at Metagenics that we just know a lot more about after today. Clinical application-wise, if you're a clinician, you're even a consumer, I don't think there's anything like I would not give SPMs for. Again, I tell people, like a candy bowl, just pop them like Skittles. There's nothing that you can't take them for. They're always going to do some kind of good in mitigating or changing that response, that immune response, to benefit you overall. I really don't know if there's anyone out there that has come back to us and even said that they're not seeing any results. I don't think I've heard that once, which is amazing.
I can tell you with great confidence that when we did the talks for creating the mouth rinse,
Mm-hmm.
we could not find a lethal dose of adding a SPM mimetic, a pro-resolving mediator. And so in none of the animal studies have we seen any unwanted side effects or toxicity, and certainly not in the human studies. If anything, there's these off-target beneficial things that are going on.
You don't have to sell me on that. I know I digress, but for the longest time I wanted to be a dentist. So I'm always looking naturopathically, like if I'm not getting somewhere, oral health, I'm asking them about it, because the amount of toxins, especially heavy metals that cavitations can hold, is unreal.
Yeah.
So, and it's so hard for individuals to have that, fixed essentially, because it's expensive, unless you are pulling your teeth out or, doing something else injection wise. How else are we going to hit the cavitations? We can't. So this is amazing to hear about this as a mouthwash. So Dr. Serhan, before I let you go, because I know you're a busy man, you have to get back to the lab.
Yep, we're gonna submit
more discoveries for us. Anything else you want to leave us with? Any tidbits before we free you today?
No, I just want to say thank you for
thank you.
your time and for reading so much. Your knowledge of the field is really astounding, and that makes me very happy. And I'm very happy that Metagenics has made it a mission to educate around the SPMs, because that and have really outstanding leaders in medicine and in surgery talking about resolution mechanisms in inflammation and how it affects their areas, coming up on their YouTube channel from our recent symposium that we had here at Brigham Women's Hospital and Harvard Medical School in January. So stay tuned for those.
We will. And we can't wait to translate some of that information for our consumers and our clinicians. But yeah, I'm hoping that after most of them hear our discussion today, that they're more willing to, try SPMs if they haven't already, and give them, like you said, a fair chance, like 3 weeks, maybe 4 weeks. Give it a fair chance, because I think they'll be pleasantly surprised for sure. Mm-hmm.
Yeah. Well, thanks so much.
Thank you
Great
so
to
much.
see you.